Hi everyone. So this video is the continuation of the disorders regarding the kidney and urinary tract disorders. So uh, in the previous video we were discussed about we will start with our discussion on the nephrotic syndrome. So I will be continuing with the nephrotic syndrome in this video. That is other presenting symptom, that is usually the child is presenting with renal edema, and other presenting symptom is the mild uriguria. Signs and symptoms of infection as a complication, and hypertension 10 to 15% of patients. And these are the indication for the hospitalization nephrotic syndrome. That is severe anasarca, which causing cardiorespiratory embracement and hypovolemia, severe abdominal pain, infections like peritonitis, urinary tract infection, pneumonia, and meningitis, hypertension, seizure, and headache. So these are the indication for the hospitalization nephrotic syndrome. Then about the so how if there is a presence of anasarca, we should give the importance to all these causes, that is kidney diseases, liver disease, allergy, cardiac disease, nutritional, liver, and endocrine. So we have to rule out all these by the investigations. Then about the investigation, that is an sub question regarding the there is a sub-question in the essay question. There is investigation. We have to diagnose at bedside by the urine dipstick examination. That is, we have to get a massive range proteinuria, that is proteinuria 3 plus or 4 plus, or we have to, again, we have to do by the heat and acetic acid test. That is also a bedside diagnosis. It is advised to the mother for doing the heat and acetic acid test to detect the proteins of the child's urine. So then further investigation and confirm. So while we get the urine dipstick examination as proteinuria, we have to further investigate the patient and confirm the diagnosis. The further investigation, which include urine, routine like nephrotic range proteinuria 3 plus or 4 plus, microscopy and culture to rule out the urinary tract infection, 24 urinary protein greater than 40 milligram per meter square per hour, and the urine protein creatinine ratio is greater than 2 milligram per meter square, and no hematuria. So these are the findings in the case of urine, in the case of nephrotic syndrome, and the serum proteins will be very low. Normally it is 5 to 6 milligram per deciliter. Low in the nephrotic syndrome, that is serum albumin is less than 2.5 gram per deciliter. That is also an investigatory findings in the nephrotic syndrome. And then about the serum lipids, cholesterol is greater than 200 milligram per deciliter. That is a diagnostic criteria for the nephrotic syndrome, and LDL bar cholesterol ratio is increased, and other baseline investigations like the serum electrolytes in the severely edematous patients to pick up the electrolyte imbalance, and CBC to rule out infection, blood culture if sepsis is present, and Mantoux test and X-ray of chest is ruled out done to rule out the tuberculosis before starting steroids, and USG abdomen. Usually it is normal in the case of nephrotic syndrome, and we have to go for renal function test. It is also normal in the case of nephrotic syndrome, and this C3 is normal. But in the case of membranoproliferative glomerulonephritis, it's C3 is abnormal. So to rule out the membranoproliferative glomerulonephritis, we have to check the C3 level, and it is normal in the case of nephrotic syndrome. And HbS-Ag, if unvaccinated for the hepatitis B, we have to look for the HbS-Ag, and the renal biopsy not routinely needed in the steroid sensitive nephrotic syndrome, but in the case of steroid resistant, we have to go for renal biopsy. Then what are the indications for the renal biopsy nephrotic syndrome? At onset, that is age, the onset is less than 1 year or greater than 8 years. At the onset, we have to go for renal biopsy, or associated gross hematuria or low C3, associated renal failure, sustained hypertension, hypovolemia, suspected secondary causes of nephritis syndrome, and AKI not attributable to. So these are the condition indication at the onset. We have to go for renal biopsy in the nephrotic syndrome, and after initial treatment, if the proteinuria is happens despite greater than 4 weeks of daily steroid therapy, we have to go for that is, we have to go for renal biopsy, and before starting cyclophosphamide or the tacrolimus also, we have to go for the renal biopsy. So that is all regarding the investigations of the nephrotic syndrome. Then about the management of the nephrotic syndrome. The initial episode of the nephrotic syndrome we have to manage with, that is before starting steroid therapy, treatment of urinary tract infection. We have to treat the urinary tract infection, respiratory tract infection, and 2 to 3 weeks of the anti-tubercular drugs for the primary complex lung if these are present. And during treatment, uh, we have to advise diet, a normal balanced diet with no added salt, salt restricted diet if severe massive edema is there, normal protein in the diet, increased protein in the diet is filtered out and excreted and causes filtration injury, and extra dietary potassium, like we have to advise to have the banana, coconut water as steroids and furosemide is used in the treatment. And then we have to manage the edema, that is response to steroid induced diuresis by 5 to 7 days. Diuretics not routinely used as a risk of intravascular hypovolemia will be the recent consent. Only indication for diuretics and nephrotic syndrome is if there is any presence of massive edema. Um, we have to give the furosemide 1 to 2 milligram per kilogram. You just have the 20% salt-free albumin. And we have to manage the infections also. That is third generation cephalosporins or amikacin plus penicillin group should be administered. And antitubercular, that is AKTs and antitubercular drugs, if started, should be continued during steroid treatment and manage stress with IV hot hydrocortisone. These are the supportive treatment in the initial episode of the nephrotic syndrome. Then we have to go for definitive treatment. That is mainstay of the treatment is steroids. Drug of choice is oral prednisolone. Mechanism of action, it reduces capillary permeability. The prednisolone 2 milligram per kilogram per day in 2 to 3 divided doses for 6 weeks. That is followed by the 1.5 milligram per kilogram per day or single morning dose alternate day for the 6 weeks. So total 12 weeks therapy is the mainstay treatment of the nephrotic syndrome. Then that is all regarding the initial episode. Then if there is any relapses happens, what should we do to manage the relapse? About 70 to 80% of steroid sensitive nephritis syndrome is relapsed. The rest for the relapse are the age is less than 5 years of onset with the 4 weeks of initial steroid therapy. That is instead of 6 weeks. Each relapse is treated with the 2 milligram per kilogram per day prednisolone till remission. That is followed by the 1.5 milligram per kilogram per day alternate day for the 4 weeks, not for the 6 weeks. It is for the 4 weeks. That is the management of the with the steroids regarding the relapse. Then about the steroid dependent or the frequent relapse. So once in remission, continue long-term low steroids, prednisolone 0.3 to 0.7 milligram per kilogram alternate day, lowest possible dose for 12 to 18 months to keep urine protein zero to trace. Use steroid sprays in rest. This is frequent relapse. So we have to give long-term steroid therapy, but there will be side effects for the steroids. So we have to give steroid sparing drugs, that is immunomodulators, if steroid toxicity or multiple relapses or high dose steroids will be there, and continue steroid at low doses also. These are the steroid sparing agents like immunomodulators like levamisole, alkylating agents like cyclophosphamide and chlorambucil, and immunosuppressants like tacrolimus, and calcineurin inhibitors like cyclosporin, and newer like a mycophenolate mofetil and a CD20 inhibitor like rituximab. These are the steroid sparing agents, and these are the side effects of each of these steroid sparing agents. This is the flow chart of management of steroid sensitive nephrotic syndrome. Um, if we draw this flow chart, it gains good scores. That is happy looking child with acute history of Thalassalca. Confirm the diagnosis by the urine albumin, serum cholesterol, and serum protein. That is the diagnostic criteria for the nephrotic syndrome. Treatment of infections, and before starting the steroid therapy, we have to treat the infections and fluid electrolyte imbalance. And after that, we have to go for the mainstay treatment with the prednisolone 2 milligram per kilogram per day for 6 weeks, followed by the 1.5 milligram per kilogram per day 6 weeks, total 12 weeks of therapy. And in the case of the no relapse, it should be stopped. And if there is in the case of infrequent relapse, we have to go for prednisolone 2 milligram per kilogram till remission. That is followed by 1.5 milligram per kilogram per day, alternate day for the 4 weeks. And the case of frequent relapse or steroid dependent nephrotic syndrome, we have to go for long-term low dose alternative steroid plus steroid sparing agent as levamisole for 12 to 18 months. Multiple relapses or high dose steroid required, steroid side effects are there. Then we have to go for cyclophosphamide or the MMF, that is the microphenolate mofetil. Then if there is no relapses, we can discontinue treatment. And if there is relapses there, we have to go for alternate day steroid plus MMF or tacrolimus. Then in the case of if we give this initial management, if there is no remission following this treatment, that is called as steroid resistant nephrotic syndrome, and we have to go for kidney biopsy in such cases. Then about the complications of nephrotic syndrome, it is also asked as the sub question in the essay question. So infection is the most, because of this loss of immunoglobulins, And because of the use of the steroids in the mainstay management, we have the immunocompromised state and the patient is more prone for the infection. The most common infection is the spontaneous bacterial peritonitis, then UTI, pneumonia, and meningitis. And the common organisms responsible are the Streptococcus pneumoniae, E. coli, Haemophilus influenzae, and Streptococci. And high index of suspicion must be abdominal pain, which may be masked due to steroid therapy. Treatment is broad spectrum antibiotics, example ceftriaxone. Then about the hypovolemia and also acute renal failure is a complication of the uh, nephrotic syndrome, that is severe disease or relapse or use of diuretics or poor oral intake or diarrhea or vomiting which results in the hypovolemia and acute renal failure. The clinical features are abdominal pain, lethargy, dizziness, and leg cramps, tachycardia, hypotension, delayed capillary refill, low volume pulses, and clamp distal extremities. So we have to manage this hypovolemic acute renal failure that is we have to investigate for that. We have that is by investigating we have to find the features like increase the serum urea creatinine ratio. We have to go for hematocrit. Urine sodium is less than 20 milliequal per liter. Fractional sodium excretion is 0.2 to 0.3 percentage, and urine K plus index is greater than 0.6. That is all indicative of the hypovolemia and acute renal failure. So we have to treat with that is we have to discontinue diuretics. Normal saline infusion over 20 to 30 minutes should be administered. Albumin infusion 5% or 20% who do not respond to 2 bottles of saline which should be administered. So that is all regarding the hypovolemia and acute kidney injury as the complication of nephrotism, and about thrombosis. Because of the loss of the antithrombin 3 through the urine, there will be thrombosis, and venous thrombosis is common. The site is the sinus venous thrombosis, central nervous system, which cause the headache and seizures. And also there will be pulmonary embolism happens that manifests as chest pain, hemoptysis, and breathlessness. And if there is also chance for the renal vein thrombosis that is present with the hematuria pain. So this should be present in mind while a patient of the nephrotic syndrome present with the hematuria pain, that is indicative of the renal vein thrombosis. Then treatment of the thrombosis is MRI or Doppler USG. Depending upon the site, we have to go for the investigations like MRI or Doppler USG. And the treatment as we have to supplement IV heparin, and along with that, we have to monitor the prothrombin time, and no molecular weight heparin also safer. Then about the vaccination, the live vaccines which are deferred till one on steroids and for the 4 weeks thereafter prefer inactive poliovirus or OPV. The hepatitis B and H influenza type B should be must, and special vaccines like pneumococcal varicella influenza vaccine yearly we have to take to prevent this infection happening. And the hypertension is one of the complications, so we have to treat if BP is greater than 99th percentile. BP should be taken at every consultation. Acute hypertension, we have to give the calcium channel blockers. And if there is chronic hypertension or steroid-induced hypertension, we have to give the ACE inhibitors or like enalapril or the lisinopril. So that is all regarding the nephrotic syndrome, and we have to educate the patient also. There is counseling regarding the relapsing cause of disease and final outcome. Teach urine dipstick at home and keep calm diary, and also we have to teach them the heat and acetic acid test. So that is all regarding the nephrotic syndrome. That is steroid sensitive nephrotic syndrome. Then little bit about the steroid resistant nephrotic syndrome. The management of steroid-resistant nephrotic syndrome is as that's a short note. Definition for the steroid-resistant nephrotic syndrome is nephrotic syndrome that continues to have the proteinuria greater than 4 weeks of prednisolone plus prednisolone therapy, or occult infections are rolled out. That is indicative of the steroid-resistant nephrotic syndrome. That is, in spite of giving the 4 weeks of prednisolone, there will be persistence of the symptoms of proteinuria, that is called as the steroid-resistant nephrotic syndrome. Then the prevalence is about 10% cases there will be chance for development of the steroid-resistant nephrotic syndrome. It can be classified into initial resistance and late resistant. Initial resistance does not respond to initial 4 weeks of prednisolone 2 milligram per kilogram per day. Late resistance is initially there will be responsive, that there will be decrease in proteinuria, but fails to respond in subsequent 4 weeks of prednisolone. That is called the late resistance. Then these are the red flag signs for the steroid-resistant nephrotic syndrome. That is, age at onset is greater than 8 years, female gender, microscopic hematuria, persistent hypertension, and non-minimal change nephrotic syndrome and histopathology. These are the red flag signs for the steroid-resistant nephrotic syndrome. Then about the clinical features, it is same as the nephrotic syndrome child, but more chances of the presentation with the complications are there. Example, hypertension or the increasing edema. Then investigation, besides routine investigation for the nephrotic syndrome, kidney biopsy is a must in every case of steroid-resistant nephrotic syndrome. So we have to go for the kidney biopsy. Common histopathological varieties are the focal segmental glomerulosclerosis, then proliferative glomerulonephrosis, and then MPGN. And treatment of this is very challenging. No one size fits all approach is used. So treatment is individualized depending upon the clinical scenario. Supportive management becomes much more important in the case of steroid-resistant nephrotic syndrome. Edema treatment, furosemide with the albumin or furosemide with amyloid is used. High index of suspicion for the complication, example, infection, thrombotic, even the hyperlipidemia. Diet, we have to go for low salt diet, useful in the hypertension or the edema. Low saturated fat diet is also required. Drugs, all drugs, in the case of drugs, we have to give ACE inhibitors like enalapril 0.1 to 0.2 milligram per kilogram orally for the 1 to 2 years, reduces proteinuria. And immunosuppressive treatments also, that is calcineurin inhibitors also used. And calcineurin inhibitors for at least 6 months plus low dose prednisolone. Example, cyclosporin plus prednisolone or tacrolimus plus prednisolone is used. If there is no remission, we have to stop the calcineurin inhibitor. And if there is partial the complete remission, we have to continue this regimen for the 1 year. Then also we have to go for microphenolic mofetil. Then also cyclophosphamide rituximab is also used in the case of the steroid resistant. That is, we have to go for the supportive management and the drugs like ACE inhibitors to treat the proteinuria, and immunosuppressive treatments like calcineurin inhibitors, microphenolic mofetil, cyclophosphamide, and rituximab. That is all regarding the treatment for the steroid resistant nephrotic syndrome. Then there will be poor prognosis for the steroid resistant than the steroid dependent. 40% chance of developing chronic kidney disease 5 to 10 years after diagnosis. So that is all regarding the nephrotic syndrome.